We now have Dr. Laura Cheever from the Health Resource and Services Administration, where she is now the lead coordinator for the Ryan White program. And Laura and I have known each other for many years, and I just want to say it's been a joy to work with her and her leadership at HRSA. HRSA has been fired up and is ready to go and putting stuff out in terms of technical assistance and so forth. So just really excited to have her here today, and she's going to tell you more about the great work they're doing. Dr. Cheever.
Good afternoon. I'm feeling a little bit set up. I was told not to have slides, and John, I got to have two. No one told me to wear a gray suit. I could have been informed, but anyway. And we play baseball in my house. I don't know very much about football either, so any analogies are going to be baseball analogies. To start with, we had two questions, and what are we doing around outreach and enrollment? Well, I can tell you that in the HIV/AIDS Bureau, which I call HAB, in the Health Resources and Services Administration, that ACA and transitioning our grantees towards ACA full implementation has been one of our top priorities, certainly for the last year as we've gotten more information as to exactly what it's going to look like. And that's critically important because the Ryan White program touches over 500,000 people living with HIV in this country. That's over 60% of those people that are diagnosed. So our ability to transition well is going to have a huge impact on people living with HIV. And I've got to tell you that the intersection between Ryan White and ACA is pretty complex. And it's going to be very complex at the national level because really, state to state, it's going to look very different depending on what's going on in your state. So what have we done? Well, I think the most important thing we needed to do was to articulate that intersection between Ryan White and ACA implementation. To do that, we had to partner closely with CMS, and I want to thank Stephen Shaw and all of his colleagues for really helping us understand that intersection. As a result of that, we have over the summer put out 6 different policy notices on Ryan White and some of the changes that are going to occur in terms of interaction with ACA and the ability to buy insurance and premium support and other things that grantees haven't always thought of very much in the past, but certainly we can do in the context of Ryan White. And we put out a particular letter showing how grantees could use their existing Ryan White resources, A, B, C, and D, all the different parts of Ryan White, how they can use those resources to work on outreach and enrollment now. They don't need to wait for any special projects or pots of money that might be coming from CMS. And our grantees have taken that call and have started moving in that direction. Once again, this is not just 2013 in terms of registration, but we're going to need to be enrolling people again and re-enrolling in 14, 15, 16, and beyond. So we're looking for the long haul as well as intensely for this year. As a part of that, what we have done is we have put on 5 webinars to train our grantees in these multiple areas, once again partnering closely with CMS. CMS has the lead in HHS for both the expansion of Medicaid and for the exchanges and purchasing insurance through the exchanges. So we need to work closely with them so our grantees can understand what that means to make that transition. And if you did miss those webinars, I'd encourage you to go back and look at them. If you go to the HAB website, we have a page on our website devoted to ACA, and you can click on and review our webinars. I reviewed one of them today because I'm going to be discussing all of these policies today at 2:30. I'd encourage any of you that want to get more information to come to that session. And the webinars are really excellent and actually taught me a couple of things that I need to know for this afternoon. The third thing we've done is we have gotten some special money from the Secretary's Minority AIDS Initiative funds this year to fund one national cooperative agreement that will be providing technical assistance to our grantees on outreach and enrollment. Hopefully that we will get that funded either this week or next week. And they're really going to be looking at best practices across our grantees to make sure that we're sharing successes amongst our grantees as we're learning the best ways to do outreach and enrollment, as well as looking at what the needs are and developing new technical assistance tools that we need to fill in the blank. The second question was really the parts of ACA that I think are going to be most helpful to our grantees and also for people living with HIV. I think by far and away number one for me is the expansion of Medicaid to people that do not need to be disabled. I mean, it was a tough time in HIV where people had HIV infection, but until they were disabled, they did not qualify for Medicaid in most states. A majority of the uninsured that are getting Ryan White services have less than 100% federal poverty, which means that in states that expand Medicaid, they will be on Medicaid, and that'll be huge for them. The expansion of Medicaid means that they'll have access to services that aren't available through Ryan White per our statute, services like hospitalizations, ER visits, that surgeries that they need that aren't part of the Ryan White program. In addition, in a lot of places, services that could be paid for through Ryan White, like specialty services, if someone needs a colonoscopy or an EGD, or someone has hepatitis C and needs to see a hepatitis C specialist, that could be paid for through Ryan White, but in a lot of places, the Ryan White dollars just don't go that far. So it's not available to people, and now it will be because they'll be insured. So that by far is the biggest thing for me. The second thing is the availability of insurance for people that have pre-existing conditions. In the past, people that potentially would have had means to get insurance on their own couldn't because it was denied because they had HIV infection. So Ryan White came in and helped pay for things for that patient because they didn't have any other ability to pay. Now those people will be able to access insurance through the exchanges. In addition, in places where Medicaid is not expanding, the Ryan White providers can potentially purchase insurance for their clients, giving them access to all those other things we've talked about, like hospitalizations and emergency room visits, because they will have access to buy insurance for someone who has a pre-existing condition. So we, in our policy notices, have encouraged our grantees to look to see when buying insurance is more cost-effective than providing the services themselves through Ryan White. What both of those things mean is if the patients increase getting insurance and we can buy insurance for people more cheaply than we can provide services, it means there's more money left over in the Ryan White program to provide all of those unbillable services that are so important for getting people to be engaged in care and linked to care. Things like navigation from your testing site into care, and helping people in care stay in care, providing treatment education services, counseling around medications and adherence, all those things that we provide in Ryan White that aren't exactly billable in a lot of insurance plans. There'll be more funding to provide those things. And we have an example in Massachusetts where they've had expanded insurance for some number of years. They've spent their Ryan White dollars differently, and they've actually changed the course of their epidemic. So my hope is with the expansion of insurance in this country, using Ryan White dollars differently, that grantees will be able to really change the course of the epidemic. Thank you.